There's nothing wrong with having trauma. We all do. You just need to do something about it. Come on, unpack the trauma with me.
Dropping a lot of knowledge so far.
Now, I'm hoping you all gonna have to send some information because you talked about the vitamins. So I'm a vitamin person. So, you know, I don't want to be taking stuff that ain't doing nothing. That's a waste of money and my time. I'm thinking it's doing something. So you're gonna have to send Dr. Marsh some information on vitamins actually working.
Yeah.
You know what I mean? And for that, because I would love to know about that. Now, just to digress, because you said something earlier, you talked about the time period between 11 and 1 a.m. Now, whose time frame is that? I mean, the American time?
I thought
Because you have
about
people
that.
around the world. What does it mean? So,
I
because
thought about that.
people around the globe, right? You got Central Standard Time.
Yeah.
I'm like,
I was like, how does
is
that
it
work?
Chinese
Yeah.
time? Or is it American time? Because then we got time.
Because you know what? I worked nights for 15 years and I was like, well,
Okay.
is it on my night shift time? Is it on my day shift time? Yeah. But Dr. Botanica, there are some avenues and some aspects to that. Statistics do show heart attacks happen between the witching hours. And it doesn't matter
Which are what?
which are
What's
1 a.m. to 7 or 8 a.m. in the morning. We would get the most heart attacks in the middle of the night. And so that's why we tell our patients, take your aspirin before you go to bed because it protects your heart.
It's really one of them one killer, I think, for African culture.
African American culture.
Yeah, we do try to speak to all cultures. I wish you guys be like this, even say, stay away from this, and that. That's what we probably need to hear too. Like,
I think
stop eating
hear,
all that fried chicken. Stop.
There you go.
Stop eating chitlins.
Stop eating, for sure.
Because I grew up we save me that fat.
Right, because they got the taste.
I would eat the fat.
Yeah.
They just it tastes good, the fat, and all. That's why I was asking Shani earlier. What do you mean? But she said the plaque buildup. What causes the plaque buildup? So I want to be like,
it's that
builds
dietary.
it up, and then I love what she's explaining, like a clause, and the water can't go through.
Yeah,
then you got to call it the plumber.
Yeah,
so that's easy to fix. But with the body, it ain't that easy.
No.
So. But I also then like how Dr. Tanner was like, let's prevent that. Eat this, change that. Rodney got a good point. We're gonna need y'all to send us some stuff so we can post it to people. Like, these are the vitamins suggest. These are what this is what Shani say. Stay, eat, do this, stay, and really put that knowledge out there. Real quick, I want to go to another one, and y'all, but if you don't mind, because I just want to make sure y'all cover everything. Diabetes.
Yeah,
that's a big one, right? When it comes to this disease, diabetes can sneak up on you. I hear people like, and it doesn't. I had the misconception, I would say that it was only applied to heavier. But I see people that are small, they got diabetes. You hear about babies born with diabetes, so that's different. But many people don't even know that they have even elevated blood sugar until the test confirms it, right? I remember a friend of mine, when he first got it, he started having all these mood swings. And then we look back later, I started researching, and we found that he was pre-diabetic. So what are some of the early symptoms of diabetes, and can this be avoided? I know sometimes, hereditary, sometimes kids are born with it, they do, but then also poor management makes it worse when they do know about it. So what are you guys' thoughts about this?
From a Western medicine standpoint, there are different types of diabetes. You have pre-diabetes, and this is where your accumulated hemoglobin A1C, or what we always hear, your A1C, is between 5.4 and 5.7, right? Or right between that that's normal range. And anything after 5.7 to 6.0, you're considered pre-diabetic. And then you have your type 1 diabetes, which we've known for years as juvenile diabetes. And this is a chronic condition that has no cure. And when we look at type 1 diabetes, it happens in your juvenile states. You know, you're either between age of birth to 5 when symptoms start to develop, and then the symptoms kind of go away, they dissipate, and then right at puberty, the symptoms come back. And that's typically when we'll see patients complain of abdominal pain or they've had some sort of recent illness. And then, you know, we see the blood sugar go up and it's uncontrollable. So this is what we call our insulin dependent diabetics, or our type 1 diabetes type 1. And again, there's no cure. Yeah. And there's no cure. And then you have your type 2 diabetics, which occur as an adult. And let me rephrase it. It's now happening in juveniles or in our 18-year-olds and up based on lifestyle. So your type 2 diabetics are pretty much going to be your lifestyle. You know, what you eat, how your diet is, what your sedentary, your exercise looks like for type 2 diabetics. And then you also have gestational diabetes, which is where the mother is pregnant and she develops diabetes. And for her, that can later turn into type 2 diabetes, and or the infant can also have diabetes as well. So there's multiple types of diabetes, which again, a lot of people don't realize. With type 1 diabetes, it's an autoimmune disease.
Right.
And so your body, so when we think of the word autoimmune, auto is self, immune, your body is attacking itself.
Right.
And it's breaking down its own natural instinct to fight against these antigens. And so, like Dr. Botanica said, it's an inflammation aspect. The pancreas is not producing enough insulin to lower the blood sugar. When we look at and so when we look at type 1 diabetes, again, it's known as the juvenile. However, you can develop type 1 diabetes as an adult. Your body is finally catching up to this autoimmune disorder, and it's finally attacking itself. So what we typically look at when we're determining if you're a diabetic or not is we use the A1C, or the hemoglobin A1C. And anything, if you're less than 65 years of age, we'd look to see if your hemoglobin A1C is above 6.2. If you are above 6.2, you are diabetic. We're going to classify you as a type 2 diabetic. And how did you get that? Your lifestyle. Everything is that fast food mentality, and a lot of people think it's a consumption of, I eat too much sugar. It's actually not sugar.
Yes, they always say it's too much sugar.
That's what we call it.
Sugar diabetes, right? Yeah.
Yes, that's what it was called.
You know,
type 2T.
Oh my God.
But let me say, it's your consumption of carbohydrates. Carbohydrates is going to be something that we need to help us to produce energy for the lifestyle that we need. But once your body absorbs and uses up the energy, what does it do with the rest of that?
Stores it as fat.
It stores it as fat. Where does it store it? In the abdomen, in the buttocks. It stores it somewhere in the legs and the arms. And guess what? When it needs it, it calls upon it. But when it doesn't need it, it increases your GLP-1, which causes your blood sugar to go up. And when the blood sugar goes up, the pancreas is like, look, I don't have enough insulin to decrease all this blood glucose because you ate too much. What did he say? Potatoes and beef. You had too much bread with your meat, too much hamburger. Then you had to top it off with the peach cobbler, which is one of my favorite things to do.
And ice cream.
And ice cream. And then you...
Type 2T.
Type 2T. And so your body said, this is way too much carbohydrates. I don't know what to do with it. So we're going to use it, and we're going to use it inappropriately. Right. And so now you gain weight because you've stored all that stuff around your abdomen. And like you said, the buttocks, and the weight just keeps going up, and it's storing it. And unfortunately, you go in, you haven't seen your doctor in 3 years, And now we say, let's check your cholesterol and let's check your A1C. And your A1C is an accumulation of how high your blood sugars have been within the last 3 months. And we can always tell when you've been telling the truth. Yes, I've been working on my diet and I've been exercising. And I say, well, the numbers here say you're at a 6.4 and I need to do something about it. So what do we do?
Preach.
Do we put you on medication? Do we tell you? I give my patients a fair chance of, okay. Your A1C is about 6.5. Per guidelines, I should start you on metformin. But you look like a reasonable person and you look like you're going to tell me the truth and say, I'm going to cut back. I'm going to do the Mediterranean diet. I'm going to start the DASH diet. I'm going to eat a little bit more healthier, eat more salmon, eat more veggies, blah, blah, blah. And I will bring you back in 6 months. And if your A1C begins to climb or hasn't dropped, then we start talking and we start saying, okay, how bad do you want your eyesight? How bad do you want your kidneys? How bad do you want that pinky toe? Because eventually over time, when that A1C becomes higher and higher, now we have a problem. Gestational diabetes, that can eventually, that is one of those where there is a cure. You have to have the baby, and moms go back to their normal regimen. However, we do tell them if you're not careful, gestational diabetes can in turn turn into type 2 diabetes.
Okay. I had a grandmother that, I think she lost a leg. I'm not sure, when she had diabetes. But didn't take care of a diet. Then I hear about people like they had to maybe remove a toe or something so the blood could flow.
Yeah.
So how's that dying because of what?
So the way I like to explain type 2 diabetes in particular, because that is actually the higher prevalence of all. And I like to explain to my patients, your tissue, your blood and the tissue that surrounded the blood is very sticky. And so if you've ever touched honey, if you've ever touched jelly, you touch your fingers together and your fingers stick together. And so with diabetic tissue, the blood sticks to the tissue and it can't make its way upstream to get to the heart, to the lung, to the brain. And so it all adheres together and all clumps up together because there's no oxygen flowing through it. Everything's about oxygenation. Everything's about perfusion. And so the higher your A1C, the more acidic your blood becomes. And the harder it is for that blood to perfuse to those organs. And so it becomes very, very sticky. And I like to say, just imagine you're touching that honey and your fingers are sticking together. And it can't perform the way it should. Your blood can't perform. So how do you end up losing a toe, or how do you end up with diabetic retinopathy or diabetic kidneys? Is when you don't have that sufficient oxygenation and that sticky tissue is not allowing those hemoglobin cells, the oxygenated cells, to get to the organ, then the tissue begins to die. And when that tissue begins to die, first it's ischemic. So, the oxygenation just gets lower and lower. And eventually, if you hold your breath for 5 minutes on your own, your brain cells begin to die. Well, imagine this is just a voluntary or involuntary mechanism. So it's not getting any oxygenation. And eventually that tissue dies. And when there's tissue death, it becomes necrotic. And when there's necrosis, something's dead. You can't bring it back. I only know one guy who brought something back from the dead. And he's been gone more than 2,000 years ago, right? So the same thing happens with diabetes. Once it's dead, it can't come back to life. And unfortunately, this is how we start to lose our limbs. This is how we start to lose our vital organs. And the number one, when we look at like renal failure, when patients end up on dialysis, it's because they had uncontrolled diabetes and high blood pressure.
Oh, this is so good. So I know one, I'm not definitely no expert of you guys in your field. I know common sense tell me to make oxygen flow is exercise. That's one, right?
That blood has to be thinned.
It has to be thin. Okay, so we know. So let's talk about preventive. Both of you guys, how do we prevent diabetes, and then how do you manage it once you already have it? You might be born with it, but you can still manage that so it won't increase to become type 2.
Well, I had one question before we move on.
Sure.
Now, this is part from my research a few years ago, and then looking at patients who get the surgeries where they cut their stomach down. I don't know which one it
gastric
is.
bypass.
Gastric.
Yes,
Okay.
and then where they go in, they're diabetic, but afterwards, where they can't hardly eat, then they're no longer diabetic. So is the pancreas clogged with fat as well? I know inflammation is a big one for all diseases, but once the pancreas, they had to basically, they were starving because you get a little teacup of water, whatever it is, the cap of water or whatnot. Then they're no longer diabetic after the surgeries, after a period of time, because it's basically like starving and the fat is going away. So after the pancreas was unclogged, then it started working again. So are you familiar with that at all?
Yeah, so we have that a lot with our patients. And what ends up happening is the body goes into ketosis. And so, like
Mm-hmm.
you said, it begins to eat all the excess fat that's sitting around. Have you ever heard of intermittent fasting?
Yes,
That's the new
I'm doing
that's
it
the
now.
new
Yes,
craze, right? Me
yes.
too. But that's the new craze. And I feel like I've never been an intermittent faster because I grew up not really eating breakfast. And so now everybody's, oh, that's intermittent fasting. But what happens is your body goes into ketosis. And when it
Mm-hmm.
goes into ketosis, it begins to quote unquote eat itself, right? All that fat that's sitting around our belly, it begins to eat us. It use that as stored energy as
Right.
nutrients. And so the same thing happens when we have our gastric sleeve or our gastric bypass patients. The body is in that starvation mode and it says, oh, well, look, the stomach is so big. It's no longer
Mm-hmm.
twice the size that it used to be. It's so much smaller, but we have all this excess reserved energy that we can feed off of.
Mm-hmm.
And it,
Mm-hmm.
it, it begins to utilize that as quote unquote nutrients. And that's how they lose that weight so quickly. Not only that, they have malabsorption and the body knows how to go into fight or flight mode and survival of the fittest.
Okay. Now, is that I've been reading about visceral fat, and the exercises, which walking seems like one of the major ones, and it's worked for me in the past.
Yeah.
But visceral fat, walking, burning that fat that's on the primary organs.
Walking, you're going to need more than just walking. Walking helps to circulate the blood. And correct me if I'm wrong, Dr. Britannica, but that's to help circulation. In order to lose the fat, you need to build muscle.
Mm-hmm.
And the way we build muscle is with weights, right? So 5 pound, 10 pounds, you need to do that. Walking helps you to burn calories.
Mm-hmm.
So if you are there and you had a Snicker bar and you're like, I probably shouldn't have had that Snicker bar. So let me burn those 260 calories. You need to walk at least an hour and a half. And not just walking, you need to have your heart rate above
Correct.
120 beats a minute and sustained in that range for a exact amount of time in order for you to
Mm-hmm.
burn those calories so that you can say, I burned 260 calories and it's not even worth it. You're mostly for your visceral organs, it's
Mm-hmm.
better to use muscle so that you can burn a lot faster and you don't have to walk an hour and a half. You can do 10 minutes of lifting weights.
And who runs it?
Our people.
Our people with bad attitudes. They don't bad attitudes. They don't treat you like no love. I was like,
I
oh my
hope
God.
not. As a
Uh,
healthcare professional, I hope they're not doing that. I hope not.
I've at those centers, those
Those
again,
dialysis centers.
I
We won't
might
say
get
any names. We won't say any
I won't
names.
say which one, but here through the grapevine for those who had to use them, the
Oh
dialysis,
no,
especially the one with this ran by my folks.
that's
Attitude, sit
horrible.
down, yeah, it's bad. They said
That's
the best treatment
horrible.
of those you inside the hospital.
Yeah,
It's different. Yeah, I just more
yeah,
monitor. But and so again, I'm not just trying to throw shade on them, but I am. But really, just stay away from that. That's
yeah.
changed the way we eat our diets.
It is.
I'm our traditional. What do you when you eat meat with carnivore? Yeah,
Carnivores.
Carnivore.
yeah. That's all I was. I meat person, meat and potato, because that's what they
Yeah,
we was taught. My grandma said she said I'd rather eat meat than anything else. Because you eat my meat all day, you gonna eat something else. Make me
yeah,
vegetables.
yeah.
And then when I got older, I had meat diet and that, but then also I remember my weight had affected that weight. But I got away when I was younger because I was so active.
Mm-hmm.
Right.
Right.
Then as you get older, like I think Dr. Barton, when you get that 40, it's
Yeah.
a whole nother
Everything
game.
Yeah.
changes.
Everything changes. Yeah.
Yeah, so,
And
yeah, so
women, and for
Exactly.
women, it's 30. For
Oh,
women, it's 30. Our hormones begin to change, and so for us, it's especially after you've had your first child.
I love you spitting that knowledge too, Dr. Chanaga. I think we just too trusting of what they put out there. They commercialize it, make it look really good, but they don't show you the fine print. I would think about two other things because I know time is valuable and we're getting closer. I want to cover two other topics from you guys where we have these experts on these panel. Prostate cancer. And we know on average 1 in 8 men will be diagnosed with this horrible disease. I hope I just never cancel my prayer. But it's a slow growing disease that typically appears later in life, right?
Yeah.
And it usually begin by age 55. What are you guys' thoughts on this? We'll start with this time with you, Shani.
Well, you're right. So prostate cancer is one of the number one causing cancers for our Black men. And the cause is unknown. If you have a family history of BRCA1 or BRCA2, BRCA is, breast cancer gene 1. So we say BRCA, and then BRCA2 is breast cancer gene 2. But typically, if those cells begin to mutate or they begin to change, again, a lot of times male patients don't realize that they have prostate cancer. And so October is Prostate Awareness Month. We're always so hyper focused on October is Breast Cancer Awareness Month, but they've paired the two to put them both because of the BRCA gene. So if you have a high family history of breast cancer, prostate cancer is probably going to be one of the number one factors as well. So we consider the age, we consider the genetics. So again, Black men. And the cause is unknown. We don't know why Black men have a more prevalence of it. But I will say I do see that more in our Black society. Family history. Signs and symptoms. So again, sometimes there aren't any. It depends on if it's metastasized or not. If it's encapsulated in the prostate cell, and your prostate is about the size of a walnut, and it's there to kind of help disperse that semen or that sperm. Sometimes male patients don't have any signs and symptoms, but if they do, one of the things that they complain about the most is erectile dysfunction. Sometimes they complain about not being able to urinate very well because as the prostate enlarges, or what we call hypertrophies, it gets a little bit bigger. It blocks the urine flow. So if you know where your prostate is, if you're looking at my picture here, let's say this is the size of the prostate and your ureter goes in between and goes around or through that area and your bladder sits on top. So if your prostate is big, it's going to compress that ureter and it doesn't allow the male patient to urinate as well. And so that's one of the chief complaints. And so we do a rectal exam. We do a digital rectal exam, which a lot of healthcare providers kind of go away with that. They go straight to the prostate specimen antigen test, which is your PSA, to determine if your prostate is either enlarged or if there's something going on. And so they will determine, if in fact you do have prostate cancer, what's the next step. So again, sometimes male patients are asymptomatic. They don't have any symptoms, or the two most common complaints I hear is, I'm unable to maintain an erection or I'm unable to get an erection, two different things. And, or they're unable to empty their bladder. They're constantly dribbling. They're constantly having to go, I just went to the bathroom 10 minutes ago. I got to go again. So those are the two most common chief complaints.
Is that painful as far as urinating part for them?
I have had patients say it's painful because, again, if the bladder is full, they can't empty it, and you start having bladder spasms.
Right.
That can be uncomfortable.
You talking about like with this pain, like when they're trying to use
when they're using the restroom.
So, but I love you said your PSA test. So
your PSA test,
but you got to go to the doctors.
Right. But you have to go to the doctor.
That's how they check that out. Yeah. So. Thank you.
And that's just the one start. And after we determine if your PSA levels are elevated, then we may do an ultrasound of the prostate. We may do an MRI of the prostate, looking at it in the soft tissue. We may even go a little bit further and doing a PET scan. And that's just to determine if it's metastasized or not. Not every patient is going to require all of these tests, but these are at least just some of the starting points. So going for your physical exam, getting your digital rectal exam. Some men are uncomfortable with the digital rectal exam. I think, like I said, some healthcare providers aren't really accustomed to doing it, because when we perform a digital rectal exam, when we palpate the prostate, we can stimulate the prostate, and we can also stimulate an erection as well. So a lot of times we don't want to do that to our male patients.
Oh, okay. Yeah, don't do all that.
Well, that's the first time I heard of a digital. So I just know old school, put the glove on.
Well, that's the professional way of saying it, right? So a digital rectal exam. Yeah.
Oh, so we're still talking about the glove.
Yeah, it's the glove exam.
Digital. I saw they got some new skins. All I know about the glove, and let's talk about. We do that.
So
she said,
I'm gonna put these gloves on.
Digital hand. He's seeing himself up in you.
Because I'm thinking like they doing toys.
You might call it a toy for some people.
And that's the best way. That is the best toy, is the digital hand. So we do that though.
Okay, digital. Like they digital. I'm thinking it's something new.
She would mention and sometimes we get calls to the direction, but we don't want to embarrass you.
We don't want to embarrass you. If I come in there, on your hand and glove exam, that's what we call it, your hand and glove exam. You don't want me to. It's very uncomfortable. So you know what? We'll go ahead and draw some blood for you, and we'll see you back in 2 weeks.
Okay.
Listen, you want to do? I want the blood test. We'll figure out from that point. You start with the PSA.
Yeah,
Right.
we'll start with there.
The last time it was PSA. I didn't know what he was talking to.
And you know what?
Exam, I was expecting for the glove. I was like, okay, here we go.
And I'm glad you said that too, because a lot of times healthcare providers, they use all these big old fancy words, and we go into, because we're in our zone. Right. And there are times, there's times where we just say, you're going to go get your PSA exam. And you're like, wait, what? They're going to do that. You're thinking they're going to do the hand test, right?
That's what I
and
thought.
it's just the simple thing of saying, we'll check your blood. We'll check your blood to see if your prostate levels are elevated. That's just as simple as how it should be. Right. But we get excited. We get in our zone and we start saying digital rectal exams.
Right.
You got to get the digital one. Before I knew my first one I did, because I had to get my test early because it ran out of family colon cancer.
Yeah.
And I told him, get in, get out.
Get in, get out.
And so then after that, when he said, "Oh, they don't do the muscle good." So
get
PSA. If that doesn't change, we good.
Right.
He said, "No, you pretty there." Yeah.
I'm glad you mentioned colon cancer. If I may add just a little bit,
I do want to get the colon. Let me just ask you before.
Okay.
Yeah, that's my next one, the colon.
Okay.
That's a big one.
Yeah, and a lot of men don't realize you do have to exercise the prostate. After 50, you have a much higher.
How do you exercise?
Yeah.
Oh, that way.
You have to use it. You have to use it. No.
I'm like, just get there, like exercise. It's like nothing. Exercise.
Yeah. Dr.
Like on a Schwarzenegger. I'm good. Okay. What you talking about?
So you talking about performing the sexual act? That's
absolutely
exercise.
You gotta exercise it. Yep.
Well, praise the Lord.
You know what? And statistics show that men who exercise their prostate often have a much has a decreased rate of developing prostate cancer.
Well, praise the Lord again. God is good.
Yeah.
Okay.
Yeah. So
the term goes.
With our wives or girl.
So we have to.
You the reason if I don't stay here.
We need to increase.
Yeah, we have.
The cardiovascular. There's some reasons.
Yes, and you tell them if you don't use it, you lose it, right?
So you tell her, Casey, you say you don't need some.
You're gonna
don't
need
tell that
it.
shit. She already know we don't mind. We exercise. Yeah, we good. We good. Praise the Lord.